Our session, where, this morning we are talking about childhood TB. I think that everybody recognizes that we are leaving children behind. I've heard in this conference, even on the HIV side, we leave children behind. I think we leave them behind even more for childhood TB. So our session is an exciting one. We are going to have 3 presenters, and up here in front I have got Dr. Mkokeli Ndlovu. Dr. Mkokeli Ndlovu is the National Professional Officer with the World Health Organization, the Zimbabwe Country Office. He's a medical doctor by profession, and he has specialist training in public health as regards health systems, policy, and management. And he has over 18 years of experience in the clinical and programmatic management of TB and HIV. And he actually once served within the Ministry of Health and Childcare in this country, looking after the portfolio of TB in the Ministry of Health and Childcare. His current role is to provide technical assistance to the Ministry of Health in Zimbabwe, as he is based in the WHO country office, to plan, implement, monitor, and evaluate TB, HIV, hepatitis, and STIs. So we are very privileged to have him in the room and to have his expertise this morning. Can we give him a round of applause? And our next speaker is Dr. Agatha Nkiruka David. She's my in-law from Nigeria. She's the Director of Research and Consultant Pediatrician at the Nigeria Institute of Medical Research in Lagos, Nigeria. She has an MBBS from the University of Nigeria, a Master of Public Health from the University of Lagos, and the Fellowship of the National Postgraduate Medical College of Nigeria in the Faculty of Pediatrics. She is also a pediatric nutrition, having received a certificate in nutrition from University of Boston, Massachusetts in the US, and is a clinical observership in pediatric infectious diseases at St. George's Hospital, London, UK. She's currently heading the Clinical Trials Research Group at the Nigeria Institute of Medical Research, and then she coordinates the child and adolescent HIV programs in Lagos, in Nigeria. She really has extensive experience in managing children with childhood TB, and is passionate about the well-being of children and adolescents, especially those living with and affected by HIV. These are our 2 speakers who are in the room. We are expecting that we will have our 3rd speaker join us online. We are confirming, and I will let him know once we are on and introduce him accordingly. Thank you very much. Can we encourage Dr. Agatha? So these are our 2 speakers for the day. And what I'm going to do, Dr. Agatha, are you ready to present? And then after that, we'll have Dr. Mkokeli present. I'm sorry, the sound was not so good. I'm hearing from the rapporteurs. Can you hear me now? Okay, so we'll try and move closer to the mic because our rapporteurs need to hear us. And may I also encourage you as rapporteurs to move up front so that we are not fighting with the sound. Thank you very much. Dr. Agatha.
Thank you very much. And good morning, everyone. It's my pleasure to be here. I want to express my appreciation to the organizers of this 22nd edition of ICASA for inviting me to, speak on this topic, which is actually close to my heart. The topic we're going to be looking at today is scaling up novel tools in childhood TB diagnosis, the missing link. Next slide, please. So and look at it using this background. Yes.
The screen is not positioned in the most ideal way, so yeah, go ahead.
Thank you very much. So we'll look at the background. What are the diagnostic challenges that children face when they have TB? We'll look at what the World Health Organization has recommended as diagnostic tools. And then we'll look at novel tools, and we'll look at what to do to scale up these tools and make sure they're effective. And then we'll conclude. Next, please. So we know that tuberculosis remains a major cause of morbidity and mortality globally, especially in children. And in the year 2022, an estimated 1.3 million children aged 0 to 14 years developed TB. This was 12% of the global burden of TB. However, 214,000 children died of TB, and this was 16% of the global burden. So that you see that more children are dying. The proportion of children dying of TB is higher than the proportion of children who get TB compared to adults. And of these numbers, you see that only 49% of those who had the disease were notified. And very challengingly, 96% of those who died never accessed treatment. And that is one of the reasons why we're here. Of the 25,000 children with MDR or rifampicin-resistant TB, only up to 16% were notified. So the problem is even worse amongst children with MDR. And then of the household contacts of adult or adolescent TB who were eligible for TB preventive therapy, only 37% accessed this intervention. Next, please. So the NTB strategy 2015 to 2035 clearly prioritizes diagnosis and timely treatment of people with TB. That is the only way that we can end TB as a public health threat by the year 2035. However, TB in children presents certain peculiarities that make children extremely vulnerable. And one of those is that their presentation is non-specific. A child with TB, a child with HIV, a child with severe acute malnutrition, they basically look alike. And the hallmark of symptomatic presumption in adults, that is prolonged cough and cough with hemoptysis, that's blood in sputum, may be lacking in children. And so the presentation in children is non-specific. It mimics, the presentation of other childhood illnesses. When the children do have tuberculosis, the disease itself is postbacillary in the sense that the amount of bacilli in children's disease is much less than in adults. And so this makes it very difficult to pick up the bacilli from biologic specimen that they produce. And then the biologic specimens are very difficult to obtain from children. We know that TB, most TB all over the world, even in children, is pulmonary. So sputum is the specimen, the gold standard of biologic specimen. But children cannot expectorate as effectively as adults. And when they do cough, a lot of children, especially the younger ones, tend to swallow the sputum, so you cannot get it. And then, so many of the children go undiagnosed, they are untreated, and they are unreported. And another peculiarity is that children who are exposed to TB, they develop it much faster than adults, within 2 years. And then they progress faster, they die faster if no intervention is offered. There is therefore an urgent need for innovative, sensitive, affordable, and rapid TB diagnostics to ensure that we get those children who are affected or infected with TB and are not getting treated. Next, please. Thank you. So this is an evolution of TB diagnostics. It's certainly not complete, but we can see that the microscopy was developed in 1882 by Robert Koch, who discovered the bacilli. And we have gone through the development of the chest X-ray in the 19th century, culture, solid culture in 1936, to liquid culture, to right now we're at the molecular level. And there are different kinds of molecular tests that are available right now. So I just wanted to give us this timeline. Next, please. So for the diagnosis of TB in children, the World Health Organization has come up with certain requirements. And for TB disease, there needs to be careful history, especially history of contact with a smear positive case of TB. And then you want to know, is there cough for up to 2 weeks and beyond? Is there fever? Is there failure to gain weight or weight loss? Is there night sweat? Not so much in children, but it could be there. Is there lethargy, weakness, lack of playfulness? These are important things to take in the history. And then, has the child been treated for TB before? When you examine the child, look for symptoms, signs suggestive of TB, and especially do growth assessment because TB is associated with poor weight gain. And then do HIV testing because we know that children with HIV are more likely to come down with TB. We know the relationship with TB and HIV. It has not ended. And then if possible, bacteriologic confirmation is very, very key because that is what distinguishes TB from other diseases that may look like it. And so WHO is actively advocating for biologic confirmation. You can do chest x-ray, but again, chest x-ray in children, features are non-specific. The classical features in adults may not be there in children. You may not see cavitatory disease and all that. And then, especially in the immunocompromised, the chest x-ray could be actually normal, whereas the child has TB. So you have to be aware of this. And then, if you think it's extrapulmonary TB, you need to look out for it. Extrapulmonary TB is actually common in young children with HIV, so we mustn't forget that. Then for TB infection is when somebody has come in contact with TB. They have the bacilli in the system, but it's not multiplying. It's dormant. However, we need to identify these children who are infected and provide TB prevention therapy for them because they have that potential to develop the disease if they're not treated. So the tests recommended for TB infection, tuberculin skin test, which I'm sure that everybody here has heard about, and interferon gamma release assays. So the current WHO recommendation for children is molecular tests that are the first line, and the first molecular test is PLHIV, and then the Expert Ultra, which came after, I think, second generation Expert MTB-RIF. The beauty of this is that, for example, it can identify TB disease, it can identify rifampicin, which is a surrogate for multi-drug resistance, and results can be available for Ultra. The results can be available in 18, so it's very fast. It's fast, it's sensitive, and it utilizes a gamma specimens, which is very good for our children. When it was first, when the Expert MTB-RIF came on board, when the Expert MTB-RIF came on board in 2010, can everybody hear me, please? Thank you. It was only sputum that it could, test. And we have already talked about the challenges of getting sputum from children. So at that time, people were going to learn about how to do sputum induction, where you give hypertonic saline to irritate the airways and cause the child to produce sputum. Very uncomfortable for children, very uncomfortable for caregivers. You need to have a room with negative pressure so that you do not spread. So it was not particularly feasible. And then gastric aspirate came on board because we know that children swallow sputum. So is it possible to recover the swallowed sputum from gastric fluids and use it to test? So we're very happy when, this became available that we could use gastric aspirates. And now nasopharyngeal aspirates have been introduced, as well as stool specimens. And this stool is particularly exciting for us because to get stool from children is not a big deal. They produce stool. Mothers don't have any problem with collecting stool and bringing it, to the clinic. One of the problems with experts is the limited sensitivity. It's not as sensitive in children as in adults, and we know why, because of the possibacillary nature of the disease. The stool is not as sensitive as sputum, but at least the sensitivity is not so bad. Sputum gives us 65 to 73% sensitivity, and stool gives 58 to 61. So it's not so bad, but when you look at the ease of stool collection, acceptability to caregivers, that's why the WHO has recommended it as a biologic specimen for using to diagnose TB in children. Then Expert Ultra produces what they call trace results. Usually they're supposed to quantify what they're seeing, but sometimes they can't. They will tell you it's trace that is there. And in adults, I think they're still thinking of what to do with trace. But for children and for people with HIV, they said that that trace should be taken as a positive result because we know that they have so little bacilli that anything you see there should be taken. So for trace results, it's considered positive in children. However, both the Expert MTB-RIF and the Expert Ultra, they still require electricity. They're not battery powered. And so their utility in peripheral centers is limited. Next, please. Then we have TrueNAT. It's another molecular test that detects, the organism by PCR. It's fast, it's sensitive, it can also recognize RIF resistance. It's battery powered, so it can be used in the periphery where there is no electricity. Unfortunately, for now, it uses only sputum, so its use is also limited in children. Next, please. So there is this antigen-based test, and I'm sure maybe some of us have heard about lateral flow lipoarabinomannan assay. It detects MTB, let me just call it LAM so that I don't bite my tongue, in urine of infected persons. It's a rapid point of care test. It can be done right there. It's recommended especially for people living with HIV because the sensitivity in people that have a normal CD4 count is limited. And so is recommended for people with HIV or severe acute malnutrition. Next, please. Then the next big thing that WHO has, recommended for diagnosis is this integrated treatment decision algorithm, which utilizes symptoms and signs related to TB, history, and history of contact as well, and chest X-ray, if chest X-ray is available. The beauty about this integrated treatment decision algorithm is that there are two types, for where there is a chest X-ray and where there is not. Next, please. Okay, so please, can we just run? These are the two, for where you have X-ray or not, and a score of more than 10 is positive for presumptive TB. Please, can you go forward? Go. Next slides, please. Go ahead. Next, to how we can scale up. These are WHO recommendations for a new TB diagnostic. Next, please. New approaches, skin tests that can be used instead of TST, which is not specific. We also can use nanoparticles. We can use point-of-care ultrasound. And I saw when I was outside that somebody is actually selling such an ultrasound in one of the stands. And next, please. So scaling up new TB diagnosis, we certainly need increased investment in research so that we can develop more sensitive, fast, diagnostics that can use easily accessible specimens from children. We need implementation research on the feasibility, acceptability, and cost effectiveness of these modalities. We need to monitor and evaluate what we're using so that we can, know what works and know how we can improve. Then we need to ensure the production and distribution of new diagnostics, especially to those in greatest need, children and low-resource communities. We need to strengthen health systems, especially in low-resource countries, WHO needs to continue to provide leadership and direction, giving us guidelines as at when due, and ensure speedy regulatory approval of products that have been tested. Next, please. Thank you very much.
Thank you so much, Dr. Agatha. I think there's so much to learn, I think, in terms of these diagnostics, but we have to remain cognizant of our time. And without any further ado, I'm going to call upon Dr. Kokeli to present to us this morning so that we know what it will take to end childhood TB. Over to you, Dr. Kokeli. Can we put his presentation up? Thank you very much.
Good morning, everyone. Okay. All right. Thank you. I hope the secretary to the IT will be with us soon, but I'll continue with my presentation. So my presentation is about ending TB in children and adolescents, and what will it take to get back on track. So next slide, please. So the next slide is an outline of my presentation. I think those are the things which I'll talk about. For the sake of time, I think we'll go to the next one. In November, just recently, a few weeks ago, WHO released this powerful tool. It's the third edition, a framework towards ending TB in children and adolescents. The first version was in 2013, the second one was in 2018, and this is the latest one, which is, I encourage everyone to go to the WHO website, download it, and go through it. So there are, next slide, please. So there are a couple of issues about TB in children. My co-presenter here has already highlighted some of them. But clearly we know that addressing TB in children and adolescents is one of the areas that we need to do in order to achieve the Sustainable Development Goal 3 targets. And we also know that the needs for children and adolescents are unique. They are not, pediatricians would like to say children are not young, are not small adults. And we also know that there are specific multi-sectorial approaches that we need to adopt. And we also know that the data frameworks that are available, they are not optimum enough in terms of monitoring progress in these special populations. And information on children might not be as easily available as that of adults. But over the past years, we have seen some achievements. We have seen the TB in children being put high on the agenda. We've seen more research and development. We've seen more tools being developed to assist in the diagnosis, the management of children. And we've also seen an improvement in the diagnostic algorithms, the issues to do with the research, children now being part of some research agendas. However, we know that progress is still a challenge, especially in case finding and TB preventive therapy. Children, especially the most vulnerable, the under 5, you will see as we go forward that we are behind. And TB remains among the top 10 causes of mortality, especially in children under the age of 10 years. Next slide, please. So this one I'll rush through because my co-presenter here has already highlighted it's the same figures, but maybe in a different format. But just to highlight that among deaths in HIV, negative children and young adolescents, 75% are coming from the under 5. So this is quite worrying. And also to note is that the causes of deaths in these children is poorly accessed. 96% of the children who died, they could not access the services. And you will see later on that with children in diagnosis, it's a challenge, but when they access the services, they do well in terms of treatment success. Next slide, please. So those are the issues. And then we also know that the treatment coverage gap, as you go down the age groups, like the younger ones, the gap is increasing. So you can see that for the under 5s, it's more than 58, it's around 58%, and the older children is at 30%. And then we also, that at the corner there, that figure there, it's just showing the availability of information in terms of disaggregation. So we still have some countries which are not having those age disaggregations so that we can monitor our trends clearly. And then this one is showing the impact of COVID-19. You can see that in 2020, 2021, the case detection trends, there was a decline, which was caused by COVID-19. But you see that red line, it shows the proportion of children against the total notifications. So you see that although there was the decline for all cases, children proportionally, the decline was worse. And then next slide, you also see the TB prevention gap on this one. And clearly you see that the red one is for household contacts which are older than 15 years of age. So you can see that the coverage is increasing for that age group. But for the children who have always been our target population, the increases are quite small, and children do not access this important intervention. And you can see that only 37% they are accessing. It's quite surprising that you miss 63% of eligible children. Next slide. And then, like I was saying, the treatment outcomes, you can clearly see that, the success rate for DSTP in children is around 91%, and for MDR is 80%. These are good treatment outcomes, but our treatment coverage is the challenge. Those are the cascades there for TB HIV, slightly lower also than adults. And also, importantly, you can see that the treatment coverage for MDR TB in children is actually said, really, 86% of children are not accessing the treatment. And this one shows the percentages, the contribution of the proportions of children who begin second line treatment. You can see that we are ranging around 2.5% to 3.5%. When we know that our proportion of children to the total notifications is around maybe 15%, but we cannot, it means clearly we cannot diagnose the MDR TB in children properly. Then we go on also to look at the progress against the UN high-level meeting targets, and people know that recently the UN reviewed or set again on the second high-level meeting. Next slide, please. Where the targets were reviewed, and we can see that, if you look at treatment targets, clearly for all age groups, although the targets were not met for treatment, but you can see on the left side, the gaps are smaller than on the right side for children, which is quite worse actually for MDR TB, the right lower corner there. Next slide, please. Then for TB preventive therapy, also you see that for people living with HIV, the targets surpassed the targets more than 100%. But look at household contacts. We are around 10% of the target. So clearly, there are issues that need to be addressed. So yes, it's a gloom picture, but like I said, we've realized some achievements. Can we go to the next slide, please? So the achievements which we've realized since especially the last roadmap in 2018, and also when we started the UN high-level meeting targets, we have seen that the advocacy for increasing increasing the care in children has increased, and also with more recognition on the specific needs for children. I think this is clear, and we have established several platforms to really look at these issues that affect children. And recently, the national TB programs have been working closely with the pediatricians and those people who manage the children to really try to include some of the interventions within the national TB programs. And we have had studies that have come up with the new approaches, new innovations. Next slide, please. And we have also child-friendly formulations for both to manage drug-sensitive and drug-resistant TB. And we also have developed good evidence-based guidelines. And also, if you go to the WHO website, you will see these guidelines. And there's a course, an e-course, which is free at the WHO website that you can take. Currently, it's for the e-course is for healthcare workers, and then the one for programmatic people is under development. Okay, so with this achievement, we still have remaining gaps. Next slide. Which is insufficient prioritization, funding, and accountability, persistent policy practice gaps. Like we have these innovations, but do we have access? Do the children have access to those innovations that, especially my colleague here has highlighted? And weak implementation of people, family, community-centered strategies that limit access to TB prevention and care services. And then persistent gaps in data, and shortfalls in research for children. So I'm getting to the last slide. Actually, the IT was behind. 2 slides. Yes. So these are the gaps which I was highlighting. And then my last one. So to address those gaps, WHO has come up with this roadmap, which is got 10 key actions that we need to address those gaps. So I think I won't go through the 10 of them, but just to highlight that they are addressing those 4 major areas. The first 4 addressing the first gap, which is the political leadership, the issues of do with political leadership, multi-sectoral engagement, and accountability. Then the second, the number 5 and 6, they are addressing the issues of persistent policy to practice. So the policies are there, stool for diagnosis, all those things, but the practice, because of lack of training, lack of resources, is not covered. Then number 7 and number 6 and 7, they also deal with the shortfalls. They also address the shortfalls in policy to practice. Then number 8, addressing the issues of family and patient-centered care. Number 9 and 10, they address the gaps in data and research and development. Otherwise, thank you so much for your attention, ladies and gentlemen.
Thank you very much, Dr. Ngwenya. I have been checking with our online colleague. We are supposed to have another presentation from Dr. Anthony Enimel. who is in Ghana. So far, we have not had connection, so he might be facing some challenges. And his topic was on the elusive conundrum in finding children with TB. You know, we always say it's so hard to find the remaining children living with HIV. It's the same. I think for TB, we still have a lot of work to find children and actually utilize all of these innovations that we've had this morning. And I was so pleased, you know, listening to the presentation on diagnostics, how far we have come in diagnostics, to the extent that now we even say we can freely utilize too for diagnostics for TB, because the other specimens that are useful in diagnosis for TB, you know how difficult that is in the pediatric population. So thank you very much to our two presenters. I know we've got experts in the room who can actually contribute a lot to the topics that we have been discussing this morning. So at this point, and I'm being reminded we don't have a lot of time left, but I think we can spend the next 5 or 6 minutes taking questions and answers from our presenters. So is there anybody in the room who has a comment, a question that we can pose to our two presenters for this morning? Yes, please.
Okay, thank you so much for the sound presentations. My name is Elize. I'm from ADPP Mozambique. I want to share some experiences that we have in our TB programming in Mozambique, up north in Nampula province, where, as it has been presented, we also come across the gap between the adult and children in TB treatment. And we come up with an innovation whereby we hired nurses, qualified nurses, that could take the clinical services to the community. And the TB contact screening was done at the family level, and where eligible, the children could initiate their TPT at family level, and also they benefited from the treatment monitoring up to the completion. And also those children that were identified with TB symptoms were easily linked to the health facility. And this allowed to break some financial barriers, because families with low income always they can take children to the facilities only if the children is sick or present any signs of symptoms. But to convince them to take their children for TB screening, contact screening, it wasn't such easy. But with the presence of the nurses, with the motorbikes and all the necessary equipment, we are able to reach out those children in contact with TB, initiate the TPT at community level, and also link those with TB signs with facility. Thank you.
Thank you very much. That sounds like a good innovation. I hear communities lead, let communities lead, and these are some of the initiatives at community level that are very useful. I have someone with the mic, and can we give a mic to the gentleman? So we take 2 questions and then we respond.
Thank you very much to the presenters. I'm Wetu Ndebele. I'm a pediatrician from NAST in Bulawayo here in Zimbabwe. I wanted to find out, thank you very much for the algorithm that has been produced that will help make the diagnosis. I wanted to know whether there is plans to also capacitate maybe even central hospitals or hospitals to diagnose particularly extrapulmonary TB, because sometimes they are referred there as very sick, and you find that there is no capacity at the higher level to even confirm the diagnosis, hence the low reporting incidence. Thank you very much.
Hello, I'm Samuel Edu from Ghana. I just wanted to find out, any of the presenters, a child with HIV, at what point do you introduce TPT? I mean, prevention of TB in a child with HIV. Thank you.
Thank you very much. Would you like to respond?
Thank you very much for the questions. For the last, children who are less than 5 years with HIV should be deemed exposed to TB and should have TPT. And then for the treatment decision algorithms, one of my recommendations, unfortunately we didn't have time, is the training and retraining of health workers at all levels and support to be able, because what you pointed out is very key. Children tend to present in lower levels of the health system where there's the capacity to diagnose, to even differentiate the symptoms and do labs is limited. So there needs to be training of healthcare workers to empower them to use these algorithms. And every national TB program should prioritize this so that we can, all get the benefit of the treatment decision algorithms.
Okay, thank you. I think she said, for the TPT, if the child who is under 5 is exposed, they need the TPT. I think we do not have the limit because it can affect even very small children. And then Dr. David also raised a very good one, which was what we're trying to discuss in my presentation when I was talking about the issues of police. Like our guidelines, our strategic plans, they are clear in all these interventions which we think. But if you look at the coverage, that is, mainly it's because of lack of resources for training of healthcare workers, like he has highlighted. You find that even at the central hospital, the capacity is not there, but yet they are supposed to be maybe the referral center to the last line of defense. But still you find that there is no capacity. So these are the issues, maybe the programs, donors, everyone, like we are saying, everyone should come on board to see how we can address those issues so that we have our capacity built so that the coverage of services, interventions which we have seen to be quite important, they reach those children. I think that is what.
Thank you very much. I was going to put Dr. Mufukari on the spot in terms of the central hospitals, because I was listening, Dr. Ndebele was saying capacity building. Here you are at a tertiary institution, you have a referral, extra pulmonary TB. How is that happening at central hospitals in your experience?
Thank you, Dr. Mshari. I think so there are two issues, the equipment for extra pulmonary TB. So they need specialized investigations. For example, CT scan, sometimes the scan is not there or it's there, but it's not working. And then the other component is the high staff attrition. So if you depend on post-service training, and then you lose those health workers for whatever reason, you might have a hospital with a lot of new staff who don't really know. So you come and you train, we can now use tools, the people leave, and then you have to train again. So I also feel like a push towards increased pre-service training for some of the childhood TB issues, so that when the doctors and the nurses come out of school, they already have some of these things on board, because post-service training has not been sustainable so far.
Any other questions from any more questions from the floor? Yes, please. And if we have one more, then we will wrap up our session for this morning.
Thank you, colleagues, for the presentations. Just a quick question to maybe the first presentation. I think we're excited about the introduction of new diagnostic tests, especially in children. And I think there was also mention of a possibility of the use of TB-LAM even in HIV-negative children. So I'm just curious to find out what evidence there is around the utility of LAM in HIV-negative children. Thank you.
Thank you so much. That is to you, Dr.
Thank you very much for that. The TB lamp that we're using at the moment is not very sensitive in people that are not immunocompromised. However, it shows better sensitivity in children even than in adults. Sensitivity is less than 50%. But there's a new TB lamp that is being developed, and some trials have gone on to show sensitivity as high as 70% in children with HIV, in children with severe acute malnutrition. That is still in development. So what we're saying is that the trial should be hastened and the final results made known so that if the sensitivity and specificity are so good, it can be deployed for use, but it's not yet in use at the moment.
Thank you so much. I am being reminded that our time is up, but I think that this session has really highlighted a few things around the gaps that are remaining for childhood TB, including that 16% of all TB deaths are happening among children. I was actually quite struck by the number of new TB cases in children every year. I mean, 1.3 million. That is not a joke, between the ages of 0 to 14. But I'm also quite optimistic that with the rollout of these innovations and new diagnostic techniques, particularly, use of stool, I think it's an easy enough specimen to collect from children that maybe we'll be able to do a lot more in terms of finding those children and making sure they are on treatment. And of course, not forgetting the issue of TPT that was brought up. We need to do a lot more in terms of TPT, and then finding our children that have TB, including strengthening household contacts and also utilizing community strategies for reaching people who are hard to reach. Because not everybody can present themselves to a facility, but we can surely find them in the communities where they live. So thank you very much for all of your participation this morning, and I hope that we were able to learn one or two things and that we will look at this roadmap. Dr. Ngwenya, please can you interact even after this session so that we learn a bit more than what we could in the limited time that we have. So once again, a round of applause to our two speakers, and thank you very much. I hope you enjoy the rest of your day, and goodbye.